You're listening to the Physio Matters podcast in association with Choose Health, and this is session 34. Welcome back to the Physio Matters podcast. I'm Jack Chew, and today I'm delighted to bring you a podcast of yet more variety. So we've had a couple of two-part series with Mick Thacker, which has gone down a treat. A variety of different feedback from people agreeing and disagreeing with me, agreeing and disagreeing with Mick. Not many people disagreeing with his take on where we're at with pain, and he really is at the sharp end of these things. And so we've not had many intellectual counters to his points, which I think is interesting when other corners of discussion around musculoskeletal problems, it does all tend to pivot in and around pain. And so I'm amazed that more and more people don't go back to the principles in which have been outlined in the last two pain episodes with Mick. So really appreciate his time as ever. And in between that, we had the episode which was, I think, application of a lot of the principles discussed, talking on our Olympic special about triathlon with Joel Filio and Paul Westwood, who again it's gone down rather well. So we're not getting as much abuse as we did on the episodes that preceded those. So we're on to a roll. I can't think we'll get too much abuse for this one either. A brilliant episode with Toby Hall that we will obviously get to in a sec. It was recorded at IFOMPT 2016 in Glasgow, which we put out a lot of material for at the time on the Physio Matters Facebook page. It was when Facebook Live first got launched, so we were dabbling with that on the way up. So you've got me and Rob preamble in the car, a few bits and pieces where we walk around all the trade stands and catch up with a few people, and then we caught up with a few big names. We grabbed Tim Watson, for example, Gwen Jull, Lorimer Mosley, Brad Neal. Who else do we have? I mean, we did some work with Sig Mickelson. It was just some seriously big names, great thinkers, just chewing the fat over the microphones with us on Facebook Live. So catch that on the Facebook page. I don't think I necessarily plugged that enough on this stream, which obviously has far more listeners. So if you want more material from us, it's on Facebook, as well as those of you that catch up with some of the stuff we've got on YouTube. That brings me to another thing that we've been doing, which is the Cause Health videos. You might have heard us go on about it. And we put a podcast out about it, didn't we, on which was over in May in Nottingham. And so all the Cause Health videos are going up, the last of those with Mick Thacker. That goes up next week. And so if you want more material, you've got a day's conference that we've edited and put onto YouTube under the Cause Health channel. So check that out. Just type in Cause Health on Google, you'll find that. Worth mentioning that many thanks to Remedy Physio and Thomas Mitchell, who's the director of Remedy Physio over in Sheffield, a private practice that I would encourage you to direct any patients you might have in that area. We often see on Twitter people trying to hunt for places to send folk where you can get people talking under a sensible message. Yeah, those guys are doing some good work over there and getting some good thinkers on their courses as well. I know Andrew Cuff's been working over there as well. He's a long-time friend of the podcast and friend of mine, if you'd admit to that. And the reason I mention them is because they've been incredibly generous in giving out some free course spaces for our patrons that kindly give us $15 or more on Patreon. So you might have heard us go on about this. We are trying to sort of crowdfund, in a sense, or support ourselves through listener pledges and people supporting us on that to try and keep us going under our current format. So check us out on patreon.com, search for the Physio Matters podcast on there. And if you were to give, for every month that you give $15 or more, which you can sign up for, then you enter into a prize draw, and it's cumulative. So apart from the name that gets pulled out of the hat, the rest of them stay in. And so the more months you support, the more tickets in the hat, the more chance you have of winning, and essentially making a rather tidy win from your investment. Now, these are big name courses. You know, we've got Toby Hall, who's on the podcast now. We've got a massive course from him coming up. Adam Meekins, we gave away free course place for Adam's course. We've got Chris Worsfield doing a course on whiplash, which is highly regarded, and a course that I'm absolutely hugely jealous of giving this away, because it's a course I haven't been on and I really want to, which is Rich Norris does a one-day course on the knee, which is highly regarded by people like Rob Tyre, who's one of our chief lads, as you know. So I'm gutted to be giving that one away, but we will do, I promise. We won't keep them to ourselves. Remedy Physio kindly donating them to our patrons to support the podcast and keep it fan funded. Right, time to crack on. This chat was, just to give it a bit of context, as I say, it was at IFOMPT. It was just after Brian Mulligan had done a bit of a show for us, which I think I described a little bit in the episode, and was in the presence of Thomas Mitchell and Toby Hall. And so we didn't go too far off the beaten track. I think we talked about headaches as much as is required, and then admittedly then touched on a number of other features in and around the manual therapy community that Toby's been involved in for many years. And so really pleased with the episode. Hope you like it too. And we will be chatting on Patreon to Thomas Mitchell about some of the courses that we're giving away, as well as a bit more detail in our differences of opinion in the assessment and treatment of other human beings. But first, to me and Toby chatting cervicogenic headache and manual therapy. Well, I'm delighted to finally be in the presence of Toby Hall, something that it's been long awaited. We made the mistake of not being able to get to Sheffield, but a colleague of mine, and the listeners might know Mark Reid, who came along to your course in Sheffield, and great reports that came from it, as well as great feedback for this interview. Toby, welcome to Physio Matters. Would you like to introduce yourself for the listeners?
My name's Toby Hall. I'm a manual therapist, physiotherapist who has an interest in treating headaches and treating a range of different things. But I seem to have graduated towards looking at treating headaches and researching headaches.
Right, fantastic. And with regards to how did that end up being? You say that as if it's an accidental thing almost.
It is accidental, but it started through my interest in the Mulligan concept. And Brian Mulligan has been one of my mentors. And as a Mulligan practitioner, I was taught how to examine and treat the upper cervical spine for patients with headache by Brian Mulligan. And he showed some assessment techniques which can have really dramatic effects. And from that, I decided that I wanted to do some research. Nobody'd done any research in that area, and I thought that it would be a perfect situation to test. So I've conducted a number of different studies, and I've just built one on top of the other one, and just continues to build my interest and learn more.
Fantastic. Now, you mentioned Brian Mulligan. Today was a big momentous day in which he was awarded with I think it's the Geoffrey Maitland Award by IFOMPT. So we're sat here. I hope the listeners will forgive us a little bit of echo, but it's a nice location for us to do so. And a deserved award for someone that's been pivotal, really, in sort of thought leading, shall we say.
It is. He's a tremendous role model, not only for his enthusiasm, but also for his innovation, really. As somebody said to me today, he said he's the only person in the last 30 years to have developed a new method of manipulative technique, as it were. So he's a truly innovative guy who's expanded my horizons, who's made me think outside the box, and really provided another tool for my toolbox.
Fantastic. Now, we'll talk a bit about headache, and inevitably I think that will walk us back into manual therapy a little bit, so we'll try and revisit that, and hurry me along if I don't go there. But with regards to headache, could you just describe sort of a brief overview of the different types of headaches, both the I know they're all treatable, but I mean in physiotherapeutic terms, which are the more treatable and less treatable?
Yeah, well, if you look at the International Headache Society, they've got a classification you can look at and download, and they've got something like 300 different forms of headache. They've got some really unusual forms of headache. You've got bathtub headache, where you get a headache when you lie down in your bath for too long. They've got common headaches like migraine and tension type headache and cervicogenic headache. So they've got all these different headache forms which they broadly classify into primary headaches and secondary headaches. The secondary headaches are the headaches that we're probably primarily interested in because there's a problem of the cervical spine or temporomandibular joint which causes referred pain into the head. So that's an easy one because you just like if you have somebody with an L4-5 that refers pain into your leg, you can treat that and the leg pain will resolve. If you've got a painful C2-3 referring pain into the head, treat the joint dysfunction and the patient's referred pain is likely to resolve. The problem comes when you look at the primary headaches, where we are still unsure of what kind of underlying problem the patient has. There's no known identifiable cause. We have some ideas about what causes them, but we can't be certain. And it seems that those ones are less clear as to whether physiotherapy can be helpful for them. There's some studies which show that we can be effective for tension type headache, and there's some other studies showing that we're not really effective for migraine type headache.
Right.
Some therapists will say, yes, we can treat migraine, we can treat menstrual migraine, we can treat cluster headache, but the evidence for that is very limited. So I think we have to be careful and not overreach what we think we can do and treat things that are inappropriate.
Right, and so what makes differential diagnosis so tricky? I mean, speaking to you, you probably don't find it so tricky compared to someone like me, but I'll admit that I find it tricky.
It is tricky. It is tricky.
Right.
We all find it tricky because headache is a disease and it's a symptom. It's difficult to know if somebody comes in with pain in the head, whether they've got a tumour in their brain, whether they've got a cervical artery dissection, or whether they've got a painful C2-3 facet joint, because all of them feed into the trigeminal cervical nucleus. So if you have an afferent input from your C2-3 joint that goes into the trigeminal cervical nucleus, can be confused and cause projecting symptoms into the head. Likewise, if you've got a cervical artery dissection, that input is going into the same nucleus, referred pain into the head. If you've got a painful tooth, it's putting input through the trigeminal system that goes into the same areas that input comes from C2-3. So the painful patient with a painful tooth also has headache. So those patients will present with similar features and can also cause changes in the muscle system. If you've got a sensitized trigeminal cervical nucleus, it can cause reflex changes in muscles. So your neck range of movement becomes altered. Can maybe cause segmental changes in movement because of segmental muscle changes. So in the past we used to say that if you've got neck pain and headache, we should treat the neck because the neck is most likely the cause. But that occurs if you've got migraine or if you've got a toothache. The trigeminal system is altered and causes projecting pain into the neck, just as much as a painful neck causes projecting pain into the face and head.
Right, so there's a big chicken and egg game going on that makes it hard to sort of pinpoint.
It is.
So therefore, tips and tricks for differentiating them between, shall we say, to start off with more broadly, the treatable to non-treatable sort of things? Yeah,
well, I think we look for, that's the topic of my talk today, is musculoskeletal impairments. And are there any musculoskeletal impairments that are unique to cervicogenic headache? And there really aren't any. So you cannot do one test and say, oh, well, you've got a cervicogenic headache, or you don't have it, so you must have a migraine. There's not that uniqueness. And we have to look at a range of features to help to try to distinguish. First of all, you're going to look at the patient's symptoms, and there's differences in the subjective complaint to highlight a difference between a migraine and a cervicogenic headache. For example, in a true migraine, then the pain usually starts in the head and with time may well spread to the neck, whereas a patient with cervicogenic headache is likely to have neck pain that then spreads to the head. The patient with a migraine often starts with pain on the right. During the headache attack it spreads to the left, whereas a patient with a neck-related problem, the pain is going to be localized on the side where they've got the joint arthropathy. So it's not likely to spread. So you've got a range of different things that you can use from a subjective point of view to help to give you the idea that there is some sort of problem in the neck. But that's not enough. We know that 50% of people with migraine are misdiagnosed, and they believe they have a migraine headache. The referring doctor might think that they've got a migraine headache, but when we carefully examine them, it turns out that 50% of them are misdiagnosed and they've got an underlying disorder involving something else. Maybe that could be the neck. So we rely on the subjective information to give us some clues, but we combine that with physical tests, which should be a cluster of tests. to confirm the patient's problem.
Yeah, that's brilliant. I mean, most of the time we walk into this question with any guest, and it's a subjective, heavy sort of detective work that you'll do. So then, if we end up in a position where you've got some subjective clues, some of which you've described, that are giving us sort of a sense that might be happening, where does your objective assessment take you with regards to those differentials then?
Well, yeah, just like if you examine somebody with back problems, if somebody comes to you with back problems, it could be that they've got some visceral disorder that's underlying their back pain. They've got a problem in the kidney, they've got kidney stone, and they're getting back pain. That's no different to a patient who's got a headache, where the problem is nothing to do with the neck, it's a problem inside the brain or something else. We need to look for musculoskeletal impairments. So we look at a range of those impairments to confirm. Gwen Joel's done a nice study showing that if you have a impairment in range of movement in your neck, if you have poor control over your deep neck flexors with the craniocervical flexion test, and if you have pain on palpation of your neck, those three factors are 100% sensitive, 94% specific at distinguishing a patient with cervicogenic headache from migraine, tension type headache, and healthy people.
And so when we're saying about range of movement impairments and things like that, excuse me, impairments, is that on a reduction on what are normal values, reduction from side to side?
That's a good question as well. What is a normal range of movement in the neck? When is range of movement impaired? We recently were looking at some research, and the study was wanting to dichotomize range of movement into impaired or not. But what is the cutoff value? Some people, it's going to be very variable, isn't it? So it's a very valid question. When do you determine?
In that circumstance, then, in that trial, do you recall as to whether that's measured against normal values, or is it measured in that other person bilaterally or something?
To be honest, I don't really know. That's a good question.
So I suppose something we can shoehorn in there, and I'll look it up.
Yeah,
It's certainly not one that I've read, but just. We've had discussion before on the podcast about the idea of human optimal, as that dogma to some extent has been questioned, sometimes overzealously and other times correctly, about what we've come to understand about normal human function and the variation within that. So when it comes to when you personally will assess objectively a neck, what sort of lookouts are you? What are your go-to things that you're finding are most correlative with it?
I think pain is the main factor that you look for. In the past, I was trained to examine movement, look for range of movement, and determine if you thought that there was some stiffness on movement, that would be something that you would treat. But more and more we realise that there is such a wide variability in range of movement, and range of movement is not typically impaired. There's a large study looking at patients with neck pain, 4,000 patients with neck pain, and they measured the range of movement, compared it to people who didn't have a significant neck problem, and they found no difference in range of movement between the two groups. So that's a big surprise for me when I saw that study, because I would typically look for impairment in movement in the past.
Yeah.
But now I think I'm guided more by pain. So if you can find a movement that is painful, that coincides and corresponds with some palpation test, that information there would guide me as to something that I can treat, and there's some musculoskeletal impairment that would be consistent with the patient's problem.
And that palpation tenderness, is that sort of typically local to where you would expect the cervical facets, or?
Well, that's right. You're palpating on what you think is the joint. I mean, you're palpating on the skin. The skin is innervated. You've got fascia underneath it. You've got muscles underneath that, and you think you're palpating on a joint structure, but you're also probably creating or looking at trigger points and all sorts of tender points. Right. So that's one aspect. So I think routine palpation in neutral by itself is not all that informative. If you have a patient who's got an impairment of flexion in the neck, and they're typing away and they're causing their headache when they're sitting in front of the computer for 3 hours, then that would give you some clue that perhaps flexion of the upper neck is a problem. So that's something I would look for. And we know from some of the research that's been done that once you start to isolate movement to the high cervical spine, there's a better correlation between impairment of movement and symptoms, headache. Whereas if you look at the whole movement of the neck, it's a bit variable. Some studies show impairment, some studies don't. So it's
because you've done some work on the upper cervical spine in terms of, I mean, I don't know, I'm going to missay it, but it's like there's some passive and active correlations and
well, yeah, that's it. That's what my PhD was. I was looking at the flexion rotation test to examine.
That was the term I was looking for.
Upper cervical range of movement, and showed some good findings in terms of impairment of movement on that test. And so impairment of rotation in the high cervical spine is better correlated with headache symptoms than looking at whole range of rotation in the neck. Looking at upper cervical flexion with retraction is better correlated than looking at whole cervical flexion. And those two movements are key, or according to the research that's being done, they're key at distinguishing people with headache from those who are healthy, and also distinguishing people with other forms of headache.
My suspicion being as well that it will have been missed to some extent. People will be looking at whole scale ranges of movement and the push back against the specificity of assessment and getting their hands on and checking active versus passive and taking that time to look at those things. It's been moved away from.
Yeah.
Clearly in this example, from what you're saying with and what I've read about the particular flexion and rotation of the upper cervical spine, that's something that is that movement away from those things is going to be to the detriment of good assessment. We've not even got to treatment yet.
Yeah, that's right. Specificity, accuracy, that's all what manual therapy is about, I think. And there is an art in manual therapy. There's a science. We try to make it a science. But unless you do the actual technique properly, you're not going to get the accurate information. Yeah, you need to do the testing well to get to know what the patient's problem is to be able to treat them effectively. Near enough is good enough for many patients, and just doing a rough job will get some people better. But if you're more precise and accurate, then I think you have a better chance to help a bigger proportion of the patients.
Right. So that's interesting. So I was. Then we went from movement to palpation.
Yeah.
With palpation, then, is that painful palpation that we were talking about earlier, or are we now talking about motion palpation of the upper cervical spine?
Well, there's two things there, aren't there? And I actually reminded me that I didn't finish what I was talking about, because you palpate a patient in neutral and look for some pain response. Then you've got that patient with that flexion impairment. You would expect that if you palpate the affected part in a flex position, the response should be greater. Yeah, if you get a correlation that in your neutral position you've got some pain response, in a flex position it's more painful, and then in a combined position it's even more painful, then it kind of supports what you're thinking in terms of a direction specificity for the patient's problem.
And so these are that patient's problem, I imagine. They're aggravating movements from what they're telling you subjectively and in their assessment of movement.
That's ideal, isn't it? We're looking for a mechanical relationship between the patient's pain and their examination findings, and that's not always possible. Many patients don't have that relationship, and in that case there are other factors at play, and we need to address those. The mechanical side of joint movement is one aspect, but it's not the bee's knees for everything.
No, never just one thing. It's always a bit of a combination. So before we get on to the motion palpation thing, you quite rightly walked it back to the palpation. So we're then looking at certain movements are aggravating, particularly in combination, palpation in neutral, then palpation into those aggravating movements and various different things. How do we... I'm thinking about me applying this, and therefore I imagine others. How do we suppress these sort of biases that come from the differences in pressure, the fact that we've just done it once before, the fact that they might be, if they're in an aggravated position, there is almost a natural expectation that comes off the back of that being more painful or tender in that spot. How might we control for those biases when we're assessing someone?
That's a good question, isn't it? What is a normal response to testing somebody in a combined position compared to an abnormal response. I think that comes a little bit from testing some healthy people and also from testing some patients with pain. So we need training in understanding what a normal response is and also what a positive response is. But if I press on somebody's neck and it causes them some projecting pain into their head, and I can then increase that by putting them into a different position that is more provocative, and then I can relieve the patient's pain by sustaining that pressure or by doing some other technique, then I think it tells me that there's an abnormality there. There's something wrong. You don't get headache by unless you suffer from headache by pressing on the neck.
Yeah, I mean, I was just going to say that traditional what you'd call trigger points and things. I remember particularly when we were practicing these things in clinic and historically even when we were students and I don't know if I can do it now on myself, but certainly sort of traps and left scap is I can get a radiation of a sensation in and around behind my head and stuff. Do you find that could be another variable that could be at play, is that we're finding people have come in with sore necks and sore heads, and so essentially a sensitive pain pattern might mean that you get these really vague sort of natural referrals of things. Might we just naturally find ourselves latching on to findings, although they're not in isolation, I guess, but I wonder, we're pressing hard onto something in a position of aggravation that then can reproduce symptoms. It almost feeds into the patient's narrative that will fuel our care, and I understand why it does. I'm always tempted by those things like anyone.
Yeah, that's a very valid point, that you find these things in people who are healthy, as you say. So I can cause projecting pain in myself by pressing in different areas, but I've also got myself, I complain of headaches. I've had headache for a long time.
I see.
And I can reproduce my own headache by, as you say, pressing on trigger points, tender points, and I know that I've got cervical impairments in my upper cervical spine. So I think it's very difficult to find a patient who doesn't have pain.
So it's like a familiar, almost like you're trying to reproduce something familiar to them, or that's my headache almost.
That's right. But finding that in isolation with nothing else, no other sign, I think would indicate to you that perhaps that's not a problem that needs to be treated.
What would be a typical cluster then? Would it be a positive flexion rotation test? Have I got that terminology right? Sorry, this time. Second time round. Positive flexion rotation test combined with these types of movements, let's say in an office worker. Could you just map out maybe a typical case that would be?
Well, first of all, the symptoms I think are very important to understand. Having understanding about the nature of the patient's symptoms, as I said before, distinguishing between a headache that might be more of a migraine feature compared to a patient with more of a cervicogenic feature. So that you've already got that picture in your mind. You've got some understanding that perhaps it's not likely to be neck-related because of the nature of the symptoms. And then you're looking at a range of tests from looking at the patient's upper cervical flexion, upper cervical protraction, upper cervical rotation in a neutral position, and then adding that flexion rotation test, which is basically a combined movement test to try and isolate the upper cervical spine, and then looking at core control over the craniocervical muscles with the craniocervical flexion test, the deep neck flexor test, together with palpation, which is not just painful in a neutral position and not just localized pain, but able to reproduce the patient's pain.
Right.
Those features are giving us more certainty. But until we can actually change a patient's headache by doing some manual procedure to the neck, I don't think we can be confident that the neck is the source.
Right, so the retest style is it part of the essential to the assessment process?
Changing pain by doing something to the neck is important.
That makes sense. Now, one of the things that again, I'm still meaning to come back to the sort of motion palpation thing in a sec, but you'd mentioned there, because I know I'll forget that, you mentioned about control. Mm-hmm. What test would you use therefore to assess function and or dysfunction of the
motor control?
Yes.
Yeah. Well, that's a good question. There's various tests that you can look at. I mean, just by looking at the patient's posture, you get some clues about the patient's likely control. You know, if you've got a forward head posture, it's going to give you some clues that they're going to move in a certain way. Problem with that is that universally everybody has a forward head posture, and every person you look at in the street or sits on the bus or is, you know, driving to work, they've all got that abnormality in posture. So our lifestyles lead us to those changes, and they makes it difficult to understand whether that's associated with a problem or just coincidental. So I think looking at the way somebody moves their neck is helpful. Looking at the way they actively move is more informative than just looking at the patient's posture.
So you're looking at sort of what looks aesthetically comfortable movement, or are you looking at as they protract and retract, whether they're able to do that in isolation? What sort of little lookouts are you doing?
I think there's an optimal pattern for movement in the upper cervical spine. If you keep your neck in extension and you avoid flexion, there's going to be associated changes in the upper cervical structures, muscles, ligaments, joints, and it could potentially lead to abnormalities in stress. And if you've got a healthy neck, that's fine, you've got no problem. But if you've had some sort of incident which has caused some changes and sensitization of your peripheral structures, then perhaps holding that position is sufficient to perpetuate the patient's pain and to cause ongoing problems. So I think you've got to look at the pattern of movement, the pattern of control, and see if there's any link to what you've found with the other tests that you've done in terms of your articular function tests.
Right, and when we see patients like that come through the door, we've not had the benefit of seeing them 3 years earlier when they never had a problem before, in terms of they'd not had symptoms before, and so we've not got any sort of control in which we're comparing against. Could that not just be sort of, like we said before, chicken and egg issue, where they move they move badly, and they, for want of a better word, badly, or they move dysfunctionally, and things like that because of pain?
Well, that's right, isn't it? Which came first? Was it the poor posture, or was it the pain that led to the poor posture? I think it can be almost impossible to differentiate in some people. But if you have a painful joint and you force that joint into a bad position, then it's inevitably going to make that worse. If you've got pain associated with a certain position of a joint, then maybe simply just changing that joint's position can help the patient change their pain. And changing the starting position, as Jenny McConnell calls it, the starting position of the joint, is able to change people's pain simply because you're not putting that joint in the same stressful position. So maybe there's not one ideal optimal posture or one ideal optimal pattern of movement. I don't think there is. But if a patient has a painful position, painful pattern of movement, if I change that and it's pain-free and it changes their symptoms, then that's got to be a good thing for the patient.
Right. Now, are you therefore meaning there's like an optimal zone of movement? Because you said a minute ago you think there's an optimal way in which the upper cervical spine is moving, but are you suggesting that if you walk away from that slightly and look at the neck and trunk as a whole, that's where you maybe would broaden it a bit more? I think so.
There's I think you can optimize human health. You can optimize joints. You can optimize muscles by having them in a good position.
Right. And so when palpate, this is what's good, because I've just remembered that I was meaning to get back to optimal, back to motion palpation.
Yeah.
So when we're feeling for, because I mean, almost one of the easier areas to differentiate, just because the differences in morphology up in the upper cervical spine that we can palpate a little easier compared to, say, if I had to pick T7 out of a line.
Yeah, that's right.
So when we're palpating up there, what is it you're trying to feel for? Because I'm not a I haven't done the secret handshakes of the MACP and the like,
No.
so I'm
To be
naive
honest,
to those things.
It's not that complicated because you've only got 3 levels that are likely to cause referred pain into the head.
Yeah.
So it's not like in, as you say, the thoracic spine where you've got all those different things that you could possibly be the cause of the pain. You've only got 3 levels. So if you've got a 1 in 3 chance of finding the painful joint, and if you carefully palpate those joints, you're looking at a combination of stiffness to movement with your pressure, and you're looking at pain provocation. So I think if you've got pain provocation, that's more important. Stiffness is something that in the past I think we were focused more heavily on, but now I think pain provocation is the most important thing. Pain provocation and pain relief with manual therapy.
So when you're feeling feeling the stiffness, I mean, we've all felt it. One side moves more than the other as we rotate, particularly in combination. How I always learnt it, particularly since Mark's been teaching me to learn it in combination with movement. And when we're feeling those things, and you've said before, you used to give them more. You used to allow them maybe to inform your reasoning more than you do now.
Stiffness.
How much weight would you give that palpation, that asymptomatic palpation sense that we train ourselves to understand? How much credence would you give that in the reasoning framework now?
I think that's much less. I think that's a much lower importance to me than it used to be in the past. I think we were, in years gone by, we used to believe that joints could become stiff because of adhesions and scar tissues and various things like that. But we know that that's not so commonly the case anymore. I mean, we did a study looking at the flexion rotation test in people with headache, and we measured the movement, found an impairment in movement, feels stiff and restricted, and then we did a study where we gave them soft tissue massage to the upper neck over, I think it was 8 sessions, and we found that the patient's movement improved without mobilizing the joint, just by soft tissue techniques.
Right.
So, it can't be a stiff joint can't be only because of adhesions. I mean, I'm sure that does occur, but it's more a response to pain.
Right, yeah, again, it's so difficult with the chicken and egg sort of thing that we're talking about. One of the things with manual therapy of any body part is this inter and intra-tester reliability that was often... It was one of the more straightforward things to test almost when the evidence-based revolution of physiotherapy took hold and we started to be trialists even at undergraduate level, etc. And so what's the sort of take on that in terms of reliability of the assessment that we're describing here?
Well, now there's been a huge explosion in research for a range of manual therapy tests, and that's grown enormously over the years. But in headache particularly, there's been a lot of research recently, just a nice systematic review. Rubio Ochoa, a Spanish physiotherapist, I think, who's done a systematic review looking at the reliability, validity, low risk of bias studies for patients with cervicogenic headache and identifying musculoskeletal impairments. And there's not many. I mean, the flexion rotation test is the most highly studied and has the highest level of diagnostic accuracy. Palpation, surprisingly, actually has a reasonable level of accuracy as well, according to that systematic review. And the cluster...
It's painful into palpation for pain, isn't it?
Pain. And interestingly, a cluster of 3 things that were mentioned before that Gwen Joel had showed, the impairment of movement, that I still can't remember if it's...
how it's measured, we'll definitely have to, we'll have to add a little appendix to this one.
And palpation and poor control of the deep neck flexors. So those are the items that have been shown to be of reasonable diagnostic accuracy and of reasonable validity and reliability. So there is, and I did a study as part of my PhD. We had 80 patients, 60 with cervicogenic headache and 20 healthy people, and we had 2 blinded examiners to use manual diagnosis to determine the level of that was the dominant level. So which level is most painful and which one do you think is most likely to cause the pain? And there was good agreement between the therapists on finding a level. but we've only got 3 levels to identify, so it's not so complex
Right.
in that regard. But we also asked them to say, well, are there any associated levels? You found that C1-2 is painful, but are any other levels painful? And more often than not, you'll find that there are multiple levels of involvement in patients with headache. And so there was a good agreement on the dominant level and also on the associated levels. But as I say, it's not so complex because you've only got 3 levels to choose from.
Yeah, but certainly an area in which specificity is a good evidence-based case for a good specific assessment, as we've described, in various different ways, both in terms of control, range of movement, palpation, etc. So we're good, we're nailed on that, that's great. We're describing these dysfunctions in and around joints and facet joints, let's say. What do you feel is therefore the cause or driver of people's pain?
Well, that's a good question, isn't it? I think there can be a number of factors. I think that joint is itself the cause of pain for most people, and there's some studies show that. Studies show that the predominant cause of pain is because of some kind of arthropathy. So you've got a painful C2-3 facet joint, and or you've got a painful C1-2 joint, and it's the joint itself that is sensitized. There are changes around the joint that causes the joint to become sensitive to movement. So, but there are some patients who have irritation, sensitization of the peripheral nervous system. The 2 studies that have looked at that indicate perhaps 10% in one study, 8% in another study have sensitized neural systems, which is which we can identify through neurodynamic tests to identify the sensitive peripheral nervous system.
So potentially, so I've not heard of that before. So like the more traditional neurodynamic upper limb tension tests would be provocative of headache. Is that?
Well, the equivalent in the upper neck. Yeah. So we can do an equivalent neurodynamic test for the upper neck to look for reproduction of symptoms. So, and the cervical spine is the neural tissue in the cervical spine is likely to be stressed by flexion, and particularly upper cervical flexion. So if you have a patient with a forward head posture, it could be that they're in that position because they're trying to protect their painful neural tissue. It's sensitized, and they're trying to protect it. And flexion in that case would be painful, particularly upper cervical flexion. But if you then measure that in a slump position, or with some additional sensitization on the neural system, and the pain is worse, then you'd think, well, it's more likely the neural system. If you then went in and palpated the greater occipital nerve, and it was painful as well as the neurodynamic test, then I think you could say, well, look, I've got some evidence here that the neural system is the potential cause of pain. But I think that's relatively less common in the upper neck.
Yeah.
More common in the lower neck.
Right. Yeah, so we'll go to the joints then.
Yeah.
Why do you feel? What's your take, shall I say, on the body of work that shows poor correlation between structural dysfunction and pain?
Well, that's maybe because in other body areas there's a lot more areas that could potentially cause pain, and so once you start to add in all those different elements, it kind of waters down what the underlying problem is, and it makes it difficult to identify one clear source. When you're working with the high cervical spine with headache, you've only got a limited number of structures that could be potentially painful, and it's less likely to be watered down, and it's more accurate.
I mean, osteoarthritis of the knee, for example, I mean, of course there are other masquerading factors and things, but that was a surprise to some when that was shown to be poor correlation, both for the amount of pain as well as pain as a binary on-off. Yeah. As far as I'm aware, it's not been shown in the upper cervical spine to have a strong correlation between those changes on imaging and
well, that's true. There's not many studies. There's a study looking at on MRI morphological changes in ligaments in people with different headache forms, and healthy people and people with whiplash headache, and they showed no difference in the ligaments of the upper cervical spine. Another study looked at X-ray changes on the neck to see if there's any difference, to see if a patient with cervicogenic headache is likely to look different on an X-ray compared to a healthy person, but there's no difference. I think that's partly because the upper cervical spine is different in its anatomy. It's unique in its anatomy compared to the lower neck. You don't get degenerative change in the upper neck like you do in the lower neck. Degenerative change at C5-6 is almost universal by the time we're at my age, or even much, much younger, whereas degenerative change in the upper neck is just not present. So you've got differences which make, I think, it simpler in the upper neck. It's a nice area because it's not complicated by all these other factors.
So there'd be more subtle sort of changes, subtle arthropathies, sort of more inflammation in and around local to the facet joint.
I noticed today at the conference there was I didn't see it, but there's a study looking at the menisci at the C1-2 level in people with trauma to the neck compared to healthy people, and they measured the menisci. I think they're using MRI, and they showed a difference in the size of the menisci in people with pain compared to those people without pain.
And the trauma being like a whiplash.
Yeah. And I worked with Professor James Taylor, who was an anatomist in Perth in Australia for a number of years, and he did a number of autopsy studies. His job was to identify the cause of death in people who had car accidents, and as part of that he took out the cervical spines of these people, and then he sliced them up, and he saw some injuries that occurred to those people that couldn't be identified on imaging, and he saw fractures. So there are people who come to our clinics who do have fractures, but who have had X-rays, but it can't be identified because of their. It's difficult to see them on imaging.
Is there any, apart from when we suspect those sorts of things, is there any a case for imaging people with cervicogenic headache? And if so, is there a particular test in which you'd recommend?
I don't think imaging is of any use whatsoever for cervicogenic headache. There's a study that I mentioned today looking at MRI on measuring the craniocervical angle, the angle of the brainstem on MRI. And they showed a correlation between the angle of the brainstem and the more severe cervicogenic headache. So that suggests there might be something that further studies down the track with more careful investigation might find, but in general imaging is no good unless you suspect some kind of red flag or serious pathology.
Fantastic. Now we'll walk ourselves into manual therapy then, because like you quite rightly said, it's about trying to change it so the assessment merges into the treatment rather nicely. And I know on your course that was how it bridged the gap between days, from what I understand. So shall we just talk to me about sort of PIVMs, PAVMs, that sort of thing, and how that would then start to influence joint-based treatment initially?
Yeah, well, you've got to find a place to treat. In manual therapy, we have some global techniques, but we also have some very precise, specific techniques. So, ideally, if we can find a place to apply manual therapy specifically, I think the manual therapy has a better chance to be effective. So we need to identify where to apply our manual technique. So if you examine somebody's movement, for example, we found that retraction is painful, and that indicates some limitation of high cervical flexion, then I'd be interested in looking at where that limitation is in the upper neck. Or, for example, rotation. It's common to find an impairment on the flexion rotation test, which would most likely indicate to me that the patient's got a C1-2 problem. We did an MRI study where we got some Japanese physical therapy students, as you do, and put them into an MRI scanner and put them in the flexion rotation test position and measured their segmental movement, and we showed that most of the movement on that test occurs at C1-2. So with some carefully applied manual procedures, we can really find where the patient's problem is and then apply a specific treatment to that.
And so are you mobilising, I mean, you're over a fairly sore spot, that's what we've sort of determined in most people, and you're trying to find somewhere to treat. Are you then applying mobilisation in that provocative position, or do you bring? It depends on severity. You bring them back, kind of like Chris McCarthy's work almost. With the,
exactly. That's
with
it.
The combined movements theory.
Chris McCarthy has got a nice approach based on the work of Brian Edwards in Perth, who developed the combined movement approach. Very logical, because you can once you've found the level where the patient's problem is, you can position the neck so that the patient receives a dose of manual therapy that's suitable for their condition. That's the tricky part, is knowing the dose of manual therapy.
Yeah.
You go to the doctor and you've got heart disease, and he measures your height, your weight, your gender, your age, and he gives you a dose of your drug that you need. When you go to the manual therapist, you get 30 seconds of mobilisation, which is not really based on anything. So I think using the combined movement approach allows you to be a little bit more precise in applying a specific dose that the patient requires to help to get better. And that depends on the patient's irritability, and their severity. So, some disorders are more irritable. If you cause them pain in the treatment session, you're likely to make them worse. If you don't cause them pain and move that joint specifically, then they're likely to get better.
So that would suggest perhaps walking back into the more comfortable positions to mobilise there certainly first.
Yeah.
Okay. Now, critics of manual therapy would suggest that that's so easy and tempting to go looking for those things and find what you're looking for.
Yeah.
And what's your take on that, which I had no doubt you'll have heard over the years?
Well, it's the fact is that it actually works. If you find that and you use those techniques, it works. There's a nice study here that's been presented, a randomised controlled trial of elderly people with headache, and they went in and found musculoskeletal impairments in these elderly people. They mobilised their neck in the way that we're talking about, and the patients got better. And they compared it to an alternative treatment, and there was a superior outcome in the patients who received the mobilisation.
How do you feel we can best understand and account for the non-specific variables that occur with therapeutic touch, with the natural showmanship, and I don't mean any flamboyance to that, I mean the natural, there's a especially when we're being specific, and in this case there's good evidence to suggest we should be specific, and so when I then apply these treatments myself, sometimes I know myself that it's hard to recognise what mechanism of effect has been there. So have you any sort of take on how we can minimise those things? Or?
I don't think we should minimise them.
Sorry, I suppose I mean understand them, or
that is another important area for research. I think there is a placebo effect from physiotherapy. It doesn't matter what you do, whether you're giving somebody explained pain, or giving them some graded motor imagery, or giving them some PA mobilisations. There's a strong placebo effect, and we know that's dictated by various things. What the placebo looks like is important. And Lorimer was talking about that here at the conference, about whether the therapist was attractive and had an expensive suit on, and all those sorts of facts. I think that's important, and I think we should maximise that.
So I was wrong to say minimise, because really it's about trying to maximise those non-specific variables. And I know Jeremy spoke about marginal gains and potentially using some of those things. That could be a point. Now with manual therapy, something that we needed to get back to was that you mentioned earlier about that you feel it is an art, and although there's some science to it and we should explore the science to it, the art can't be ignored. So what's your sense of that art then? Is that about skilled hands, etc.?
Definitely, it's about skilled hands. It's if you see somebody who's good at the art of manual therapy, it looks effortless. The patients respond in a much better way compared to somebody who's a bit rough and heavy-handed and blunders into the examination, blunders into the treatment. It makes a big difference. And when you have somebody to apply a technique on your neck, often when I'm teaching a course, I'll get people to do it on me. And sometimes it's very painful, and it's really horrible to have it done to yourself. Whereas somebody who's done the technique and practiced it and practiced the art, it's a totally different thing.
I think I'd be terrified if I was holding Toby Hall's head.
No,
I think I'd be
no.
like stiffening up and stuff.
I think it's a good thing to do. To get people to
practice on you and you practice on them.
Yeah, that's right. Because it's only by feeling those things that you appreciate how different it can be and how much better it can be.
Now, I'll be honest and say my take on sort of manual therapy, the art science sort of thing. For me, it's about what I position myself as someone's relatively in between, in that I certainly wouldn't discount it like some do, but equally I am somewhat sceptical of the feel sense that has been suggested to be found by people of expertise. And my place to pitch it is at a level of competence, and the suggestion that there is a certain limit to what one human pair of hands can influence on another human being, and that interface, knowing from people like Bialowski's work, to suggest that the neurophysiological effects are certainly more significant from his work and from what we've come to understand of how pain emerges from people than the biomechanical. So whilst training, I think that it can't be neglected, and is to some degree at the moment being neglected, and I've said this before on Twitter and elsewhere, I think we're going to end up with a generation of people that can't feel alignments because they're not good at getting their hands on people. So I'm concerned about that. But for me, the training should be to a level of competence rather than to a level of the real depth of skill of repetition. Kind of like people, I've got a friend who can balance stones on stones on stones on stones, and whilst he does that, no matter how good he gets at that, he can't make them hover and float. No. And I think that to some extent the expertise and skill, because of what we used to think we used to be able to achieve to the tissues, I feel that dogma still exists. So anyway, I've put my cards on the table.
Well,
I don't know what your thoughts are on that.
I agree totally. I think in the past we used to be fixated on the technique, and we didn't realise how to apply that technique and make that technique better. And we used to think that you had to practice the technique for a year before you would become a skilled therapist and you could use it. But we've shown that we can train somebody within an hour to do a test like the flexion rotation test. A naive therapist, they're competent. They can assess the movement. They can get and determine a positive test or a negative test, and then they can be shown how to do a simple treatment to affect that. So I don't think we need to be highly trained and to be practicing for months and months before we become competent.
Yeah,
I agree with that. Totally.
Of course, so yeah, we're more aligned there. I didn't know if I was being outrageous. I know some have been upset with my position on that before, but clearly we're well aligned on that. Now, with the manual therapy side of things, I feel the more I come to understand human function and talk to more and more experts such as yourself, I feel like there's a case that we can understand why doing more can influence people. So when we are doing things to people, with people, for people, and collaborating with them somewhat, it sounds a funny word to use, but intimately, when we're holding things like their sore head in our hands and things, it's a very, very influential part of their life when they're struggling. So I can always sort of understand the effects of doing more, but when people do less or back away from things and still manage to yield the same result because the relationship is still good, I sometimes I personally in my own journey have found that really difficult to sort of comprehend when I thought it was the specificity of the intervention that was doing so. So would you say that the people that are able to treat these things with the more hands-off approaches, or just something different, I suppose, than what we've already described today, what would you understand of the mechanisms at play there?
So we're talking about headache.
Yeah, neck pain and headache. Yeah.
Well, I think you can sometimes overtreat people. I think there's a case for minimising your input to try to make a change. And a good example is cervicogenic dizziness. Sue Reid is a physiotherapist in Australia. She did a master's and a PhD, and looking at the impact of upper cervical mobilisation, Mulligan's mobilisation with movement, on patients with cervicogenic dizziness. And she showed that after just 4 to 6 treatment sessions, you could have a sustained benefit on people, which was sustained even 12 months later, compared to a placebo. And so minimal input could have such a dramatic effect on people.
And in the longer
sustain long-term change after doing some minor movements of the upper neck. And I think we assume you have to do something sustained and do something strong, and you have to be vigorous and you have to break up adhesions. We don't have to do that. We can have a positive outcome by simply applying some simple interventions.
And in terms of traditionally, I don't know if I can say traditionally, I think it still stands and sort of should still stand, is that it's been that you'd apply some manual therapy and then you'd use some exercise-based modalities to try and extend the sort of treatment and effects of that. Now, where does that lie in this headache sort of paradigm? What sort of exercise management is used?
Well, I think that's key. It's a combination of exercise with manual therapy for any body part. I think you need to combine exercise. Your exercise has got to complement what you've done in the clinic. If you only apply a treatment in the clinic, for sure the patient's going to feel better. And some people you can fix them by just doing something simple in the clinic. But for the long-term improvement, exercise has got to be helpful.
And what sort of exercises have you found to particularly useful?
Well, that's got to complement what you've applied in the clinic. So
right.
If you've applied some change in motor control for the patient to try to alter the position of their neck, they've got to practice that at home. And if you've mobilized their C1-2 joint, they can go home with a self-treatment that can maintain that improvement. So I think I would try to mimic the treatment in the clinic with the exercise that the patient does at home.
Some of the intricacies in and around motor control have been recently, some quite good quality studies have been shown to be no more effective, still effective and very effective. In fact, good effect sizes from what I recall, and the listeners will be able to access these studies. We'll be able to just show them those alongside this. But there was good quality motor control exercises and then general exercise of the neck, and both did well, but no tangible difference between those groups.
That's reminding me that in the upper neck, you don't need to necessarily be precise and to do motor control exercises. Simple strengthening, dumbbells in your hands, shrugging your shoulders, TheraBand around your head, moving your head in different directions. TheraBand strengthening, general dumbbell strengthening can give pain relief and give sustained pain relief. Nice study in Scandinavia where they stratified patients to 3 groups. One group received strengthening with stretching, another group got endurance training with stretching, and another group just got stretching by itself.
Right.
And the group that did the best was the strengthening. Non-specific, general strengthening,
right.
But those patients got good pain relief, but whether those patients got permanent pain relief is another question.
Yeah.
There's a nice study that looked at neck pain, and they gave the patients general strengthening exercises, and they showed that they had to work for 4 weeks before they got some pain relief. Many patients do exercise and they give up after a while. They try for a week and say, look, I did that, didn't work.
Yeah, 4 weeks of finding no effect at all of something like that that's boring. I can imagine they did fall off the wagon.
But we know that neck pain and cervicogenic headache can be episodic. Yeah, so it comes back. If you do some strengthening today and stop doing it 4 weeks down the track, this episode may be better, but your long-term nature may not improve. And there's some work from Gwen Joel's group in Queensland that motor control exercises changes motor control, and it also changes pain. Strengthening exercises change pain, but don't change motor control, so they don't allow a long-term improvement in the patient's condition.
Does it matter that it doesn't change motor control, considering the fact that motor control doesn't correlate necessarily with headache, or from what we gather so far, future headache?
Exactly. That's the issue, isn't it? You can look at posture and see very mixed studies to see if there's a correlation between poor posture, poor movement control, and patients with cervicogenic headache. But that's because not all patients have that problem. So if you isolate the subgroup of people with cervicogenic headache whose problem is related to poor motor control, for sure the long-term improvement for that patient has got to be to improve their motor control. But treating everybody with that same approach is not maybe going to be so helpful.
And that's often a reasonable sort of comeback on these trials, really, is that they there has to be some way in which they can't be individualised to certain extents,
right.
and therefore is it that the results are washed out almost by that lack of individualised care?
Well, I hope that's the case. I hope that's the case, because if it's not, we might as well pack up and go home, because we don't need to be physiotherapists to do dumbbell strengthening exercises for somebody's neck. You don't have to have a 4-year training program, 3-year, whatever it might be. In Australia, we have a 3-tier system. We have new grads, level 1. We have people who do a master's for a year, which is a level 2. And we have people who do a 2-year training program on top of that to become a level 3 specialist. Why do you need a specialist to give somebody dumbbell strengthening exercises?
Yeah. Does that hope sometimes fuel our own? Because I'm with you there. You know, I'd be concerned about keeping our job and keeping the profession that I love. I mean, I always remind people that when I'm critiquing anything, it's like I'm the Physio Matters guy. I really do think it matters, you know, and I do hope that this profession can go onwards and upwards. But sometimes it does seem that the evidence feels to rail against us. Does sometimes that concern, that hope, the hope that we can be more specific, that hope that the more intricate, skilled postural normalisation exercises or correction of form or motor control, that we want that to be more important than it might be.
We do want that, and I think that's a good point. That I think perhaps, you know, we do want to complicate our profession to give that some credibility to the specialisation program, for example. And there are people who do make life complicated, make our assessments complicated. I hope I don't. I hope to me it doesn't seem that way. But, you know, it is possible that we are artificially inflating the problem just to create our own jobs, keep our own jobs.
And we won't even know we're doing it some of the time. Yeah. I suppose my question on that is as well a difficult personal one in a sense, not that I'm being personal with you, but I mean for all of us to question ourselves on, is that, you know, you were saying before that you've sort of stepped back away from necessarily being as interested in the palpation, sense and feel, and recognising that it's the pain reported by the patient on. Yeah. So those things that you've stepped back from, does it feel intuitively uncomfortable to step back from some of the things that you've held dear? Because I know change in practice can be
it's
tough.
Very uncomfortable. You know, I've been working as a physio for many years, and when I look at what I did when I was a new graduate, I feel embarrassed about what I used to know and what I did. But that's what we knew then. And
we did our best.
we did our best, and with new knowledge, you have to change. If you don't change, you're lost. And there's a difficulty in change in some people. Some people don't even keep up with the latest information. They don't go to courses, they don't go to conferences, they don't read things, they don't have access to journals. So how can they change? But you are challenged in your belief systems. And I've been challenged many times that I had to change my belief systems. You know, we used to do all sorts of things to people which we now know is not helpful, and we have to move on. And unless we do that, we're not going to get better. We're not doing the best job we can for our patients.
And that is, I mean, as whilst we say it's tough, it is essential, isn't it? Now, if we were to say in the last 12 months, well, let's say 12 months gone, and then 12 months ahead of now, if you had to be a mystic, what has changed in your neck and headache course in the last 12 months, and what do you project might change? What direction of travel?
Well, I think the changes in our understanding of the influences on the trigeminal cervical nucleus. You know, the trigeminal cervical nucleus is the keystone to understanding about headache, and we know more and more about that now. Just the presentation we had today at IFOMPT, a major part of the presentation that was given by Carol Courtney was on central sensitization and some of the drivers for that, and how perhaps, and thinking about what Jeremy Lewis said about that small additional percentage change that might be achieved by doing some small things to the patient can have an influence. You know, and one of the big things for me was learning about sleep. Sleep is such a powerful thing for people with neck problems. There's a study I was telling somebody about earlier that they found that in patients with neck pain who were going to the doctor, GP, specialist, or physio, the major determinant of recovery for them was how well they slept. 5 years ago, we wouldn't have been worried too much about sleep, apart from knowing, are you waking up at night and is the neck in a bad position? Have you got a good pillow? Have you got a good mattress? Sleep is a very important factor. But that's just one factor that feeds into sensitization of the trigeminal cervical nucleus.
And we've got an exciting time ahead as we learn more about that to try and work out that chicken and egg story that I keep using that analogy for, because is the sleep affecting the tension, affecting the sensitivity, affecting the stiffness? Or vice versa, are those symptoms disturbing sleep and perpetuating those cycles, and therefore subtle changes in work routines, habits, postures, etc. We'll look forward to the future. So do you see that being the direction you feel your course is going to go?
Well, I think we need to do that. We need to move forwards. We need to understand the other causes, drivers of people's pain, and we need to have a better understanding about that. So, we're learning a lot about all those different factors. We're learning about the psychosocial aspects, and that's a major underdeveloped area in cervicogenic headache. It's a bit more well known in migraine headache and tension headache, but it's a major area that has not been investigated.
Yeah, and one across all over the body, and something that we've not purposefully avoided, but something that of course is new to this particular body part, isn't it? And something that's been touched on the conference, but one for another time as the science further emerges. Just as a little summary, today was a really interesting morning in which, as we mentioned at the start of the podcast, Brian Mulligan rightly awarded and took to the stage for what was a really exciting and interesting, such an enthusiastic time in which his enthusiasm is just infectious. Now, from talking through what we've talked through today, is you are a product of that system that is then also a product of an academic framework in which Brian admittedly has become a little frustrated with and disenfranchised with to some extent, from what I can gather reading between the lines. Not just that, I'm not just trying to snip it 20 minutes or whatever, I mean from previous work. I don't think it's controversial for me to say so. Although another time Brian can speak for himself, but just out of interest, how do you see Brian's opinion on that, being someone that is sort of torn between those two worlds, if I may say so?
Yeah. Well, Brian is he's a mentor of mine. He's a role model of mine, and he's had a tremendous influence on my career. So I really respect his opinion, because he's got I don't know how many years, 50 years or more of maybe more, 60 years of clinical experience. And he's used his techniques over a long period of time. He's obviously had tremendous results. He goes around the world teaching people who then go away and practice his techniques, who research his techniques. There's thousands of articles relating to the Mulligan concept showing a positive effect. But he's seeing that those techniques are not being used in practice because they're not being taught to undergrads. So manual therapy is not being taught to undergrads as it was in the past, or maybe it's just not being taught effectively across the board. So I think it's very frustrating for him to see a concept that he's worked hard to develop, that's got some sound scientific evidence, not perfect, there's a lot more to do, there's a huge amount more work that we need to do, but it's not being adopted. As he said, for a tennis elbow, there's studies in the British Medical Journal that show that his concept is effective for the treatment of that condition, but then it's not taught to an undergraduate level.
And do you think it's not being... I mean, I'm not aware of any school that doesn't teach it, but is it just that it's not being held in the same regard or respected like it once was for various reasons, as there is now just different fads, trends and fashions, I guess?
Yeah, it's hard to know, isn't it? I think there's a heavy focus now on evidence-based practice, and I think you can look at evidence in different ways. And if you were to interview 10 different people, they would give you 10 different opinions about the evidence for manual therapy.
I do.
Yeah, and
absolutely.
That's the crazy thing. And you look at the conference here, and there's different opinions about the evidence. So, we think evidence is evidence, and it should be hard and cut.
As if it's clean cut. No,
but
it never is. Never is.
And you look at systematic reviews and meta-analyses, and you look at what's been tested, and you look at the original study, and they're very poor. The way that the treatment was provided, the way the study was set up. So there's all sorts of errors in evidence-based practice. So I think sometimes evidence is taken literally and not considered, and then people throw away those techniques and they don't use them anymore.
Too quickly to disregard certain things, certain skills. When Brian's up on stage there and he's calling for come up if you've got, I mean, I only walked in on the latter parts of it, although I've seen some clips and things, but come up if you've got tennis elbow, and then the very popular and very effective evidence-based technique in which there's a mobilisation and with movement over the radial head, and he does that up on stage, and you see that, and he's how's that feel? It feels better, right? And he's doing that show. From what I gather, as one of his what am I trying to say? Trainees or one of his students and
his teachers,
mentees?
One of his teachers.
One of his.
I'm a teacher of the Mulligan concept.
Do you see yourself in your 80s, hopefully and rightly, I imagine, being awarded as such in a conference like this? Can you imagine yourself, although I'm not trying to transpose you onto his personality, would you be allowing yourselves that liberal attitude towards the biases and those other factors at play that we were talking about earlier?
I think there is an element of skill in getting a person off the floor of a conference and treating them in front of a group of people. And I don't have that ability in the way that Brian does by any means. And so I wouldn't do that. I wouldn't attempt that, because I think you run all sorts of risks of choosing the wrong person, not assessing them properly, and so there's a potential risk for doing that kind of thing. So I wouldn't do that.
Yeah, he's a brave man. So you're not going to be on stage doing the flamboyant show that we experienced?
Not as I think of it at the moment, no.
Not yet. No, fair enough, that's great. I spoke with Mick Thacker recently on another podcast, and again, I don't know when this will go out, so I can't speak in proper times, but we were having the discussion, and Mick was of the opinion, which I completely understand, that he said the clinician should be going home exhausted because they should be thinking these things through so hard, and whilst I understand and agree with him to some extent that it's an exhausting environment in which to do that for increasingly fewer rewards sometimes, and an increasingly difficult landscape to work. So it was a breath of fresh air. It divided people. I think there's a lot of talking that goes on, particularly with Lauren following him. I think it was just something that challenged all of us. But we can all certainly be agreed, Toby, to finish, that it was certainly something that we can aspire to that exuberance.
He's an inspirational guy, and he's inspired me, and that's why I'm here. If it wasn't for people like him, I wouldn't be here. You aspire to people. Bob Elvey, I've aspired to because of his quest to help people. These guys want to help people. They're devoted to improving people's lives. They're not doing it for their own betterment. They're doing it because they perceive a need, and they can help people in ways that we haven't been able to do in the past.
Toby, is there any way in which people can access you? Any resources that you particularly want people to hunt down other than the ones we've already discussed?
Well, I've published some articles on examination and treatment of the neck. We just recently did a webinar with Chris Murphy on this kind of topic, and I'm also just joined Twitter.
Fantastic.
Which I'm about to post my first tweet, and I'm really excited about that because my Twitter name is Dr. Toby Hall. I couldn't have Toby Hall, so I had to have something a bit different.
That's all right. So it's still your name.
I feel a bit embarrassed about being Dr. Toby Hall, but it gave me a way of keeping my name.
Was Dame Toby Hall taken? You could have just thrown that out there. That would have caught everyone out, wouldn't it?
Toby
so,
Dame
what's your
Hall.
First tweet? Is that like a pre? Is that been pre-written?
I was in the process of writing it just before we had this meeting. So
well, you can edit it and you can talk about this. If your first tweet is to announce this, then I'll soon be pressing retweet. It'd be great to have your voice in and around on Twitter, at least for us to fire questions out. And if you can get involved, and especially if you see me talking about any upper cervical faux pas or anything that you feel you can weigh in on, then please, it'd be lovely to have your voice on there. So thank you so much for your time. Really appreciate it.
Thank you.
Thanks, Gav. And there we have session 34. Thank you very much to Toby Hall and to Remedy Physio, Thomas Mitchell, for setting up that interview, and for hosting Mark Reid, who kindly fed into giving me some insight into Toby's course ahead of that interview. Really helpful. So many interesting things to sort of muse on with that, especially it's a while ago. And I reflected on this conversation, reflected on the IFOMPT conference, and I've only just released my reflection and sort of review of the IFOMPT conference on Physiopedia. So if you want to check that out, check out my social media at choose_health on Twitter, and on Facebook you can find me as Jack Chew, or under the Physio Matters podcast, and at TPM podcast on Twitter. The main reason I mentioned that is because I've actually found it on reflection really frustrated with the lack of keenness and willingness, or even feeling of necessity to move on or progress with what is general consensus over the science of manual therapy, as well as the art of manual therapy. And so I wrote on this blog about that, and it's sort of interesting to listen back to this podcast and sort of think about how I sort of tried to elaborate a little bit of that in this interview, and especially another one that we did with Gwen Jull, which was after this, where I sort of was a bit confused over some of the old guard's take on these matters. So please have a read of that. I think it'd be of interest if this interview's been of interest. And I'm really keen to hear your thoughts on this, and I think hopefully we can spill it over into a question and answer session with Toby that I think Thomas is planning on Twitter, and we of course are available for further discussion on social media about all these topics. It's the debate rages on. As for the headache stuff, I think it's brilliant, and I think that this is something that I use whenever I see anyone with headache. I just think it's interesting how it spills over, because we've got some evidence to show some specificity that's required, particularly with pain provocation and palpation, flexion, rotation tests, so we can be a bit more specific at the upper cervical spine. Some are seeing that as being a sense that we might be able to become more and more specific when other things have gone the other way. So there's certain bandwagoning that can occur, and people like to find themselves in trenches where they just want to agree with old principles rather than move on to more broad and varied and more complex ones. You know, you can tell on this podcast we don't land ourselves too typically in dichotomies. So if you like what we're on about, and you like the variety that we're providing, and you like conversations that you don't hear elsewhere, then please do think about supporting us on Patreon, Patreon, and search for the Physio Matters podcast on there to support us in any which way you can financially. Or please review us. I haven't mentioned it for a while, but reviewing us on iTunes is really helpful for our ratings. If you are a long-time listener, you might never have done that, but reviewing us on iTunes is really helpful for us finding new listeners. We've been a bit complacent on plugging that of late, but it would be really helpful. So if you check us out on there, we don't ask much of you, do we? But there's lots of different ways in which you can find us. So take care. We'll see you next month, and we will also have a Physio Natters available with Mary O'Keefe talking about what is it called? Cognitive functional therapy. On the next Physio Natters with Rob Tyre and Jack March. So check that out in a couple of weeks' time on our YouTube and Facebook pages. But until then, you've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Bye for now.